So now it is my pleasure to introduce our final speakers, Annette Kasenko and Cynthia Pross, both registered nurses at the Surrogate Decision Making Committee, also known as the SDMC, which is part of the New York State Justice Center for the Protection of People with Special Needs. As a reminder, this session will be recorded for educational use at a later time. Annette and Cindy?
Hi, good morning. This is Cindy Pross, and as Lauren mentioned, I am a nurse with SDMC. I've been working with people with intellectual and developmental disabilities for about 30 years at not-for-profit organizations and state operations in various roles. And let me start our video and I'll let Annette introduce herself.
Hi everyone, my name's Annette Kasenko. I've been a registered nurse here at the Surrogate Decision Making Committee for about 4 years now. I have about 27 years of experience as an RN, both with nonprofit and state-run facilities. And I think we'll just get started. Next slide, please. So the topics today we're going to cover is the Surrogate Decision Making Committee program. We're going to talk about the Healthcare Decisions Act. We're going to take a look at the SDMC forms, compliance with the HCDA. We're going to talk about our end-of-life hearings and the SDMC consent. Next slide. So the Surrogate Decision Making Committee program was established through the Mental Health Hygiene Law, Article 80, as an alternative to the court. As a means to meet the needs of people with disabilities to obtain informed consent for major medical treatment in a more timely manner than through the courts. The program is not meant to replace family members or even the court process for consent. The program offers advantages to the patient, inclusion for the patient and their natural supports in the whole process. It's a personalized decision-making consideration given with preferences and opinions regarding treatment the person may have expressed over the years. And also there's no fee to our program, and another perk to the program, we try to do our decisions in a timely manner. Next slide. SDMC eligibility, all current or former service recipients in need of medical procedure, and also they lack the ability to provide their own consent, and they have no legal authorized person to provide consent on behalf of the person, on this person's behalf, and the SDMC or the court may provide consent. Next slide. Informed consent. It is the cornerstone of the surrogate decision making. People with disabilities have the right to informed consent like everyone else does. Adequate information should be provided to make a decision about the treatment or procedure. The healthcare provider needs to make sure that the person understands the information in order to make a capacitated decision with full knowledge of the risks, benefits, and alternatives. The next slide. So once again, SDMC is an alternative to the court. It's a free alternative, ensuring timely access to health care. We do include the individual at the meeting, family, and other supports at our hearings. Due process rights are recognized with appropriate notifications. And the next slide. SDMC, we review and process all declarations. We operate in all 62 counties of the state. We have 6 regional contract offices who are the ones that set up the hearings and run the hearings for us, and we do run some of them ourselves. We have 4 specially trained volunteers to attend the hearing and make the determination and issue consent. Our volunteers consist of medical professionals, nurses, doctors, dentists, PAs, OTs. For example, some of our medical professionals are New York State licensed professionals. We have attorneys admitted to the New York State Bar. We also have advocates, people who have worked in the field on their everyday professional life, or some people volunteer to make sure that people with disabilities, people in our programs and our service system receive the supports and services that they need to lead productive and happy lives. And the 4th panel member is a family member or a former client. These panel members are either themselves a former recipient or a family member of a service recipient. Their sensitivities and their experiences are certainly valuable in helping to make a decision for someone. We have approximately 800 volunteers across New York State, and consent is issued to the providers at the hearing. And the next slide. Oh, and this is what I just reviewed. So these are our panel members and the 4 panel members that we have for our hearings. And next, the 3 decisions that are made at the hearing. The first, we address these 3 areas at each hearing and in the order as they're listed. We first look at capacity. Does the person have the capacity to understand the risks, benefits, and alternatives to this medical procedure? If capacity is determined, if the panel determines they do have the capacity, then the hearing would stop at that point, and it would end, and they would be able to make the decision for themselves. The second part that is addressed is legal and a legal authorized surrogate. The panel will ask if there is any legal guardians, healthcare proxies, or family that are involved and willing to make the decision for the patient. And the third has to do with best interest. Is the procedure that is requested, is it in the best interest of the patient to have the procedure done? And this is where we have a lot of medical questions and testimony from nurses and other providers on behalf of the patient, and the patient themselves. If they have some understanding of the procedure, they ask questions to them directly about that. So those are the areas that are spoken about at the hearing, and determination they're voted on. Those 3 areas are voted on at the end of the hearing, whether they're going to give consent or not for that procedure. Okay, Cindy, you're up next.
Okay, next slide. Do you hear or see me? Okay, next slide. There's nothing on this one, just we're introducing the Healthcare Decisions Act. Okay. Healthcare Decisions Act. In 2003, the Surrogate Court Procedures Act was created to grant authority for guardians, family members, and SDMC to make healthcare decisions regarding life-sustaining treatment for persons with intellectual disabilities. Next slide. Before this, let's see. Prior to the Healthcare Decisions Act, there was nothing in place to allow the guardian who had been making medical decisions all along for this person, like surgeries and colonoscopies, to have the ability to decide what life-sustaining treatment was appropriate to withhold or withdraw to ensure compassionate death. The same with SDMC. We could not provide consent for a DNR or any end-of-life plan until after the Healthcare Decisions Act and a little bit later. The argument had been that the state had an absolute interest in prolonging life if the person's wishes had not been stated by the person themselves. So a person who may not have ever been able to articulate those wishes, there was no way to know what they wanted, and the state ruled in the favor of prolonging life, even when it wasn't in the person's best interest. And if we go to the next slide, here's an example of a situation. And why was there an absolute interest in prolonging life? The opponents to a surrogate, a family member, or SDMC making an end-of-life consent, they were concerned about euthanasia, some slippery slope, or discrimination. When a surrogate looks at the quality of life for a person with a disability differently than the general population, so the protections were in place with good intention. However, here's an example with Sheila Pouliot of a situation where this didn't work in her best interest. And this is a big reason why the Healthcare Decisions Act was eventually passed. And I apologize if I'm not saying her name the way the family does. That's the way I learned the name, Pouliot. She was a 42-year-old woman with profound intellectual disability and physical disability. The last few years of her life, she experienced chronic and debilitating illnesses and repeated hospitalizations. I'm sure many of us in the field know of this sort of scenario. In December 1999, she was admitted to the hospital with aspiration pneumonia, upper GI bleed, and a painful non-functioning intestine. Her condition was terminal and grave. The physicians and the family agreed to withholding life-sustaining measures and managing her with pain management in December. However, within 5 days of starting the plan, the attending physician was ordered to provide resuscitative measures by the New York State Attorney General's office. The artificial nutrition and hydration was reinitiated, but she did not tolerate it. She had swelling and projectile vomiting for 2 months until there was a court order to stop these as they were medically contraindicated. She died several days after. So this was one of the cases that prompted advocates to work with the state representatives to create some type of legislation to address the decision-making rights of guardians for compassionate end-of-life care decisions. Next slide. The Healthcare Decision Act allows surrogates to make end-of-life decisions, but there are also protections to mitigate the risk of things like conflict of interest, misdiagnosis, or discrimination. At Surrogate Decision-Making Committee, most of our cases are major medical decision-making. Most of our cases are things like colonoscopy and surgery and dental under anesthesia and things like that. Typically 10% of our cases involve end-of-life care plans. This year, it might be a little bit different because routine medical things have been suspended due to COVID-19, and there have been an increase in end-of-life cases, especially downstate. Every year, the number of end-of-life cases increases. These are difficult decisions. Every end-of-life case that we have is slightly different with different ethical challenges and dilemmas. Next slide. There we go. The Healthcare Decisions Act continued here. The special protections outlined apply to all surrogate decision makers for people with IDDD, as has been discussed today. This is family, guardians, and the decisions that go through us, the SDMC. The Surrogate Decision-Making Committee's processes meet the requirements of this act and provide compassion for the person's life. Because we make them with a personalized approach, and if we make any error with these decisions, we err on the side of life. We are careful when we're talking about making the ultimate decision on behalf of people who are unable to make these kinds of decisions or clearly express their preferences about their own wishes. Next slide. Here is that hierarchy we've been talking about all day. I find this, this is the same hierarchy that you're gonna find in 63311. Somebody had asked about who can make decisions for medical care outside of end of life. And it is roughly the same list. So find that in 63311. You're gonna go down, and as we've discussed, it's a hierarchy. You start at the top. If there is an actively involved spouse, if guardian, it doesn't come to us. You don't pick and choose on the list. If the person exists and is willing to make the decision, they make the decision. If you don't like the decision, you have to work it out. You can't skip them and come to us till you get a decision you agree with. That question came up yesterday in a phone call to us. We can't. It would go to a court of jurisdiction, or you will accept the person's decision. And if you think it's not in their interest, court is your resolve if you can't work it through. We do have some success helping you work some of these things through to allow if one of those people on the list is not willing and available, or it would be willing to let us make the decision. Those things come up also. All right, as you can see, we're at the bottom of the list before you come to us. Make sure that there isn't someone better suited to make the decision. When the 4 panel members review the case and participate in the hearing, they'll be acting as the substitute decision maker, as a judge, on behalf of the person's best interest. Next slide. Okay, the important thing to note about our jurisdiction is that we can make decisions on end-of-life care for people who lack the capacity themselves, have no other surrogate, higher in the hierarchy, and people have to have a developmental or intellectual disability. We don't have the ability to make decisions for people with just a mental health diagnosis. If it's a dual diagnosis, as long as there's intellectual developmental disability, it's us, but we don't work in the mental health processes. We can connect you with somebody at mental health to work on that. Also, we can hear cases for people who have an ID or DD diagnosis but have never had formal services. And this comes up very rarely, but it's a good thing for us to know that there's no gap there. Next slide. As we've discussed all day, the exception is healthcare proxy. If a person has a healthcare proxy, it wouldn't come to us. Certainly wouldn't come to us because that person is outside of that 1750B process. That healthcare proxy can make the medical decisions as in the general population. And the second one is brain death. In the event of a confirmed brain death, the Healthcare Decision Act process is not required. So there are occasions where we start cases and we're in contact with the hospital and they're doing testing to see if there's brain death. If it comes to brain death, it's not something that our panel gets involved in. It is a medical matter at the hospital. And next slide. It is the physician that makes the determination of what is life-sustaining treatment. It's a medical determination. Some examples: mechanical ventilation, artificial nutrition, dialysis could be a life-sustaining treatment. And it might also be things like surgery or chemotherapy or radiation. And sometimes we work with doctors to make sure that they're including these sorts of things. If one possibility is that the person have chemotherapy and radiation, but you decided against it for a particular reason, perhaps we need to put that on what you're withholding. And we talk about that and we sort out whether it fits best with something that you're withholding. Next slide. This surrogate decision maker should advocate for things that are efficacious, and that means that is effective and likely to be successful. We want all 4 panel members at the hearing to advocate for all treatment that is in the person's best interest, but no treatment that is considered futile or hopeless. So that will come up, that the G-tube, would placing a G-tube actually make sense for this person? Those sorts of ethical considerations come up, and there are times when it is not really efficacious. The Healthcare Decisions Act process requires that an attempt to determine the person's wishes and/or moral or religious beliefs is made. And how we do that for a person is not verbal, is not always clear. But we try to get as much information from you and to make you aware, so you're prepared for hearing, that question will be asked, that we should try to figure that out and know what it is we're going to have in testimony. We might talk to caregivers or correspondents or providers. Has a person ever expressed an opinion about end-of-life care? For example, have they made comments to staff when a person had saw his father on a mechanical ventilation? What did he think of that? What did he say about how he would like to be in his final days? And this, I believe we're on to Annette. Back to you.
Yes. Next slide.
Next slide. Thank you.
So in this section, we're going to review some of the SDMC forms for end-of-life care decisions in compliance with the HCDA. Next slide. So the SDMC process basically follows the same rules as the Healthcare Decision Act, where maybe a family member might be making decisions. We have the same requirements. So we determine any moral or religious beliefs that the person may have. We follow the 1750B decision-making standards. Our decisions are issued in writing and are witnessed. There are objections rights, and there is a appeals process also noted. And notifications are made following the SDMC hearing process. Decision, excuse me. Next slide. So the SDMC end-of-life care packet, it consists of 4 forms. We have the 300, which is our declaration. That's the request made. The 310 is the certification of capacity. The 320AB, that's the medical requests from the physicians, the attending and the concurring physicians. And then the 330 is supplemental medical information that has all the information that currently on the patient, what's going on with them, and has some other medical information to support the request by the physicians. Next slide. So the 300 is completed by the declarant. That should be someone who knows the patient fairly well. A lot of times it's the RN at the house or the care manager, or it could be the house manager. We want someone who knows the patient and can speak to their daily activities or their wants and possible if there's any family members involved with the patient, someone who knows them fairly well. And also any moral, oh, I'm sorry.
Yeah, for end of life, oftentimes we work with the social work at the hospital. That's another good person to declare it.
Yep. And it also, in this form, it identifies who's spoken to the patient about the proposed plan. That's important, that someone explains what is being requested and see what their understanding is. So Cindy, if you could bring up the 300. We're just
Yes,
going to
we're
show you the
switching.
form and just,
We're switching to my screen. Is everybody with
Yeah.
me? Okay.
yes. So this is our 300 form. The first page kind of is just a checklist of what should be in the packet. Just helps the declarant to make sure they have everything that we need in order to process the case and send it off to hearing. So if you scroll down to the next page, this is where we identify the patient, where they're living, and everything on our forms. We always tell the providers it's important to fill out everything. We want to know what county they're from because we have our contractors that cover certain counties. So we need to know where to send the case. We need to know what type of residence they're in. Are they in family care? Are they in an ICF? And as you can see, there's several areas they could check off with where they're from. So the declarant, and we do specify on our forms, you know, who should be the declarant, someone who knows the patient well, can speak to capacity, surrogacy, and best interest. Those are the 3 things that we address. So as much information as we can get, you know, fax numbers, emails, all that is what we need. We always want an alternate declarant listed because if the declarant can't be available, if they become sick or something happens, we need to have a second contact person. We need to have someone who's the keeper of this case and can get us information that may have been left off or any information that we might need in order to process the case. So as we scroll down the different parts, we're asking for, you know, the agency nurse, the manager, the care manager. If hospice is going to be involved, we ask for, and we don't always get the hospice information because sometimes they're not sure what agency they're going to use. But if you have it, that's great to put it in. And hospital contact's very important, obviously, because we need to set the hearing up. So we need to have a contact to see, especially now, you know, we're not doing in-person hearings. So we need to know is video available at the hospital. So we need a contact person who can help us with that and also help us coordinate. We need a physician available for the hearings, especially with our end-of-life hearings. We want testimony from a physician. So that hospital contact is more than likely the person we call to ensure that the physician would be available for that hearing. We also like to know if there's any other service providers for the patient. And the reason we ask for this question is our panel members are all volunteers, and some of them are still working for agencies, or they might be affiliated with an agency that the patient is affiliated with. So we would ensure that that panel member would not qualify to be on that panel because there would be a conflict. So that's why we ask for that question. In this next section, we're asking for any legally authorized surrogates. We want to know if the status of the parents. And we want information on the surrogates, even though they were like, well, why would they have a surrogate? Why would they be coming to us? Well, sometimes our surrogates, they don't wish to make decisions. And sometimes when it comes to our end-of-life decisions, they're not comfortable with it. But we still want to know who they are. And we want to know that they've been contacted, that they're aware of the situation and what their response is. So that is why we have these sections. And sometimes they're not, maybe they can't get a hold of them and they've been trying. And we really want to know what the provider has done to contact them. You know, why can't they get a hold of them? You know, have they sent a mail? Have they sent certified mail? We ask all those questions when we're doing these cases. And then correspondence. We have community advocates, family care providers, and And sometimes this might be a sibling that does not wish to make decisions, but we do want to have them involved with the hearing, so they would get a notice of the hearing, and certainly they could be a part of the hearing, but they have already determined or stated that they do not want to make the decision, so we list them as a correspondent. And for the hearing, we want to know where the patient is, because we want them to be a part of the hearing. We want to ensure that the declarant has read not only the 310, but the 320AB, and they're aware of what the physicians are asking for. And we want to make sure they list here exactly what they're asking for. They would get that right off the forms. We want to know if they are withholding or withdrawing artificial nutrition and or hydration. We want to know if they anticipate hospice. And if they don't check that, we always ask sometimes, if they might need it down the line, you can certainly get consent for it. If you use it, fine. If not, that's fine too. But if they anticipate it, they should check it. This next section is very important. The patient needs to have things explained to them. The medical request needs to be explained to them. Even if they're in the hospital, and we get this question often, well, they're unresponsive or they're intubated. Basically, they still have to, someone has to attempt to address that with the patient. Maybe there's no response, at least it was attempted. And if the patient is responsive, if say they speak another language or they use sign language, then the proper avenues need to be taken in order to communicate with that patient. However they communicate, it should be provided for them. In this section, we ask the declarant to answer these questions based on their knowledge of, that's why we want someone who knows them fairly well. Why do they think that they can't give consent for themselves in their own words? And then, why do you feel it's in their best interest? And sometimes it's really difficult for the providers to answer these questions. And the nurses, we kind of talk to them about it, and try to help them out to come up with expressing this. Communication needs, obviously, we want to know if they need an interpreter, another language, sign language. They use a communication board. There's a number of scenarios that we would need to know in order that the patient is properly given information. And then it's important that the declarant signs off on the forms and dates it. Okay, so that's our 300. And back to our slides. The next slide, please. Our 310 form is our capacity form. Now on our 310, the attending physician needs to fill it out with a consulting physician. It can be another physician or a licensed psychologist, and they must confirm that the person lacks capacity. The next slide. Now, one of the capacity evaluators must meet the following criteria. And I know Laura just spoke about this in her presentation. That has to, and you'll see on our form, Cindy's going to bring that up in a minute here. That third page asks, has the criteria. So one of the physicians or a licensed psychologist has to be able to check off one of these boxes on the 310 page 3. And if you want to bring that up, Cindy, we can show them exactly what we're talking about. So
Do
our
you see
certification on capacity for end of life. This is our 310 form, and pretty much just has the patient information, the attending, and they talk about their lack of capacity if they feel the patient does not have the capacity to make decisions. If there's any evaluations, they can put them in if there's any recent evaluations. Any testing. A lot of times they're not available, sometimes they are. So the attending signs off on that first page. And then on this second page, this is where we have a consulting physician or a New York State licensed psychologist. And this is where, you know, we ask them the same questions that the attending answered, but if you move on to the third page, this is where we want one of the physicians to be able to sign off to check one of these boxes. They only need one to check one box to qualify. And Laura reviewed this earlier, so this is what we're looking for on our forms. Okay, the next slide. So now we're going to move on to the 320AB forms, and two physicians need to certify that the patient has one of the following: a terminal condition, permanent unconsciousness, or a medical condition that requires life-sustaining treatment, and that it's irreversible and will continue indefinitely. Next slide. Two physicians certify that the extraordinary burden of continued life-sustaining treatment in light of the person's medical condition other than the person's intellectual or developmental disability. So they can't say because the person has a mild ID or profound ID, you know, that's why they want to do this. No, it has to be a medical condition, because we have seen that actually on some of our forms, and we have to, you know, send it back and say, no, we need a medical condition for this. And that the expected outcome of the long life-sustaining treatment, aside from the person's intellectual disability. Next slide. So considerations of the impact on the patient, you know, is the treatment painful? Is it futile? Is it without benefit? Will treatment not change their outcome? Does it fail to improve their quality of life? And those are all questions that come up, and questions that we, you know, we want answered on our forms. Okay, the next slide. Considerations for burden of treatment. Is pain and suffering outweigh the benefits? Would treatment merely prolong the person's suffering? For instance, there, when we talk about feeding tubes for patients who are in end-stage dementia, that's usually more painful for them. Is there any benefit to the person's functioning or quality of life? Is continued treatment futile? Is there any hope of recovery or restoration of function? Next slide. Excuse me. Okay, artificial nutrition and hydration is always considered separately. So withdrawal, withholding of artificial nutrition and or hydration. The physicians have to agree that there's no hope of maintaining life. and the artificial provided nutrition or hydration poses an extraordinary burden. Cindy, do you want to bring up the 320AB form? Excuse me.
Certainly.
Now, this is a form that is filled out by 2 physicians, the attending and a concurring, that are in agreement with the proposed treatments. Typically, our end-of-life care decisions, most of the time they are expedited. Not always, but most of the time they are. You need information on the attending, the concurring. Cindy, if you don't mind, my voice is kind of going right now.
Oh, okay. I can certainly take over here. No problem.
Just go
okay,
through the form. Sorry.
Yeah, I'll get through the forms. This is the part I usually do. Okay, so on the second page of this, it gets into those criteria. And again, we're following along with the requirements of the Healthcare Decisions Act. So if you recall from previous discussions here, it's that terminal condition, permanent unconsciousness, or a medical condition other than IDDD that requires life-sustaining treatment, is irreversible, and will continue indefinitely. So CHF, COPD, progressive end-stage dementia, things like that. So the doctor picks one of these, and the 2 doctors sign on this page. Whoa, okay, skip that, because this is asking me to sign because I clicked there. All right, I don't want to do that. Okay, so then we go on to this page, which is the actual plan. And this is going to match up with your MOLST and MOLST checklist. And it's going to guide us in the exact wording of our consent. It's really good for us to have this absolutely right, because we're going to walk into the hearing with this already pre-printed on your consent, ready to go. And yes, we can make some changes if you get to the hearing and different things are discussed and decided, but that makes it really complicated. So we try to tease out some of these potential hiccups when we talk to you or the doctor on the phone, you as the declarant, or we talk directly a lot with physicians on this. So it might be a DNR, DNI, it might be with withdraw mechanical ventilation. Whatever is checked here, remember, you as the declarant, you go back to that first form and make it match exactly. So don't think you can shortcut. Write this whole thing out. Withhold future hospitalizations unless pain or severe symptoms cannot otherwise be controlled. Yes, really, write it all out. That ensures that you are asking in the request for exactly what the doctor specified. So the declaration is full and complete. And we affirm that you as the person bringing this paperwork together understand the complete picture. So whatever else is picked here, sometimes it is the soup to nuts whole thing here. And we kind of talk about these things as we go through it. Other things that might be withheld or withdrawn, this is where you get into things like dialysis or transfusions or other things like that. IV fluids, that is separated out here for a particular reason, because you may need a rationale. You need one of these, and if you pick that that these IV fluids will place a burden, tell us what that burden is. Okay, and then this, we're going to move it on the form, but this part right here, what is the burden of the life-sustaining treatment? Let's say I didn't have any of this, and I was just simply going into the DNR, DNI. What would be the burden of the DNR, DNI? So this 5B actually goes up here. And this is a subset, this artificial nutrition and hydration. But why would a DNR be, and we've seen some of those rationales. Why is a DNR not going to be in their interest? And then pick on the next page whether there is comfort care or comfort care with hospice services or neither. Then we get into the outcomes. What is the expected outcome of continued life-sustaining treatment? What is the alternative? Well, there's full code with CPR and dialysis. And dialysis would mean that we are sedating the person for 4 hours, 3 days a week, because he would be resistant to medical treatment. And that would go back to what is that extraordinary burden? Well, dialysis, there would be an extraordinary burden for some of the people we support. Then it gets into justification. Why is, in my clinical opinion, why is it important? Both doctors, again, these are physicians. On this form, the 320AB, these are both physicians, MDs or DOs, not the nurse practitioner guiding care or PA. That's the way the law is written for our work. They both sign. Okay, and I'll go back. Let's see. Stop
Thanks,
sharing,
Cindy.
and we'll go back. There you go. You're on, Annette.
Thank you so much. And next slide. Can you go back to 32?
Wow, why did we skip over 31? Some of the slides might be hidden if you're managing the slides. I know sometimes they get goofed up. And so if it skips from 30 to 32, it's in the slide deck, it might be hidden. Okay. We know we got that, 31.
The next one.
Isn't that something? They're hidden.
Well, I'll just review them anyways. The surrogate decision-making decision is issued in writing. It's signed by our panel chairperson, and it is witnessed by the SDMC representative at the hearing. Now, the consent is valid for the DNR, DNI, and other orders to withhold or withdraw life-sustaining treatment. All interested parties receive a copy of the consent, and there's no expiration date. Cindy, did you want to bring up a copy of that?
Of a decision?
Example? Yes.
An example of a decision. Okay.
Yes.
I will do that. And I am going to share my screen. There we go. It is right here.
So this is an example of what a decision would be for an end-of-life case. It lists, the patient's name. It lists the date of the declaration, determination. It lists there what was asked for, DNR, DNI, and so forth. It's written on there. It lists the attending and concurring physician for both the capacity and for the medical decision. And then for our end of life care decisions, there is no expiration date on those. And that's pretty much what the consent looks like. I don't know if you have anything more to add, Cindy.
No, you can see that it's signed and witnessed. We of course crossed everybody out here. And you can see their check marks here because it is issued but not checked or signed until after the hearing, but they do it right at the time of the hearing. If this is in person, they hand it over to the doctor at the hospital to start putting it into effect. Hand over a copy to MHLS so they can start considering no objection to it. All right, so let me go back to your PowerPoint.
Now, the notifications do go to the person, Mental Hygiene Legal Services, the OPWDD State Operations Office Director or CEO of the residential agency, or the Commission of OPWDD or designee the Regional Office Director. Gets notice of the hearing or gets notification of the outcome. sorry. Okay, so the right to object to a decision listed here. These are any of these people listed has a right to object. Okay, the next slide.
Is this
for
me,
you,
Annette?
Cindy.
Tell me.
Yeah. This is you,
Okay.
Cindy.
All right. So we'll talk for a few moments about the end of life hearing. Let's see, 35. We're recording this presentation in September of 2020. We're still trying to limit close contact due to COVID-19. Typically, we have all these hearings in person, but right now and for the near future, we're going to have everything by video conference. Next slide. The participants at a hearing. Let's start with the person. Most of the SDMC end-of-life hearings are going to take place in the hospital. Typically, the person is in need of some urgent orders. They're usually expedited and they're usually in the hospital. They may take place in a conference room near the unit where the person is receiving treatment. The patient will be visited by at least one of the SDMC panel members prior to the hearing. Right now, we can have a panel member visit by video, one or more panel members. Providers will come to the hearing. Staff from the residence will receive notice of hearing, or the members of the team that they feel are can have pertinent testimony will be brought in. It's really up to the provider group to send the appropriate people to the hearing. We will invite the nurse, the care manager, and the RN for the house, and we will have conversations with them about what is expected for the hearing. But it's up to them to pick people who will have things to contribute to the process. They'll provide the pertinent information concerning their baseline. Is this the way the person usually acts? Is this the kinds of things he would usually be able to participate in? They may have information about the decline in health. What was his life like? What mattered to him? They'll have information about family, visitors, previous beliefs and religious and moral beliefs. So we really try to have a good representation from the people who have been caring. The physician, the hospital may have information about the current medical treatment, prognosis or burden of treatment. We really try to have the treating physician, NP or PA testify. There isn't any rule that it has to be a physician there. If it is the palliative care PA, that's wonderful. Good for you. That's going to be perfect. We really find that palliative care practitioners are great at giving testimony. Our panel, if you recall, there's only one of those folks who's a medical person. So I often try to tell physicians or PAs, speak to the panel like you're speaking to family. Don't get overly technical. Explain it so that it is accessible to every member of the panel, not just the nurse on the panel or the physician on the panel. Palliative care folks are great at providing a complete picture, understanding about explaining burdens of treatment and those sorts of things. And really, they often have more experience with our process in general. The panel will be at the hearing for panel members. The panel member who visited the patient before the hearing or at the time of the hearing, if now that we're doing video, but the panel member who visited, if it happened before, would look at observations of the patient, of their direct interactions with the patient. They don't interview staff. They do not ask the nurse what's going on with the person. Their job is to talk to the person, and they share objective information regarding what they asked the patient, whether or not the patient knew about the proposed end-of-life care, what they had, what their understanding was, or alternately, if the patient is not conscious, were they able to communicate with the patient what was going on? There may be interested parties or correspondents like a community advocate, a family care provider. MHLS acts as a legal representative and legal advocate, and the SDMC coordinator. That could be us from our office, or that could be one of our regional contractors in the various areas of the state. Next slide. The procedures, like I said, they're usually expedited. Sometimes we do things within a day or two. Expedited, we like to say, is within maybe 5 to 7 days after receiving. We really should get an answer. It's as quickly as possible. There isn't anything quicker that we are aware of that we utilize. People say, well, he needs the answer before the weekend. Well, it is Friday at 12:15. I don't know what to tell you. You haven't started the forms. I don't see us getting it all put together in time for the weekend. And we and MHLS do not have hearings over the weekend. Yes, start the process. Yes, let's try to get everything done we can today, but know that there are limits to what we do because of the resources we have, the timing that we have, the legal notification things we have to do. So expedited, we may be able to manage in a day or two. We have really great volunteers who can pick up the ball and read all of the information, all the things that we send them, the 80 pages of documents, dense medical history on a person in that short period of time. And they review the medical and social background and come together to have these hearings. In typical times, we have the panel visit in person. We do visit, there is still some visitation of the person or the person invited to the hearing by video. There's a review in the testimony that there is not another surrogate above us. So if you look at that 1750B criteria, sometimes within the hearing, or I would say it is standard within the hearing, that they will ask, does he have a mother? Where's mother? Does he have, was he ever married? Does he have a spouse? Does he have an adult child? And they'll go right down that 1750B list to elicit from you to get into the record that there isn't somebody other than SDMC, other than them, that panel, legally empowered to do this. At this time, sometimes we get some member of the staff piping in, oh yeah, he's got a sister. And really, we love to hear about all that before you step in there, so that we can discuss whether that person, who that person is, and whether they would qualify as an actively involved family member, and that you are given the tools to describe to the panel. We don't consider that person actively involved. For you to have the understanding of the rule of who could be a surrogate, so that you can adequately explain it to the panel how this person does or does not qualify. And the same with the fact that sometimes surrogates who typically make decisions are not available immediately. So he moved to Florida and we haven't spoken to him for years. We tried to reach him since he moved to Florida, and now the number is disconnected and we sent mail and it's returned. If you can provide that story, we can easily move on and say that that person is not a surrogate. But we don't want to get bogged down. So anybody who could possibly be a surrogate, please talk to the SDMC nurses about that, so that we can make sure you're given the tools to adequately explain that when we get to the hearing. As Annette said, our decision is issued in writing, and you saw a copy of that. Next slide. Is this you, or is this me?
No, it's still you.
It's still me. Okay, best interest considerations. Sorry, I didn't write on my, let's move on to the next one. Okay, we are a bit behind. Okay, so in best interest, what's the unique situation that's going on here for this individual? What are the other medical conditions? What are behavioral considerations? Are they likely to pull out that G-tube? or reactions to care. Dialysis would be such a burden for this particular person because he would have to be sedated in order to let people touch him for that period of time. And quality of life and the same thing. Where will they live? How much different would the life be? How would they react to not eating if they were given a G tube? Would they have to move? All of those things come up in our consideration of best interests. Next slide. It is required in the Healthcare Decisions Act, and I'll just let you see that there's all of this. We've discussed this today. We're really talking about the dignity and uniqueness of every person. Next slide.
Okay, so hospice and comfort care. Next. So we do sign consent for hospice. We sign off on rights and admissions, patient rights, consent, and admission to hospice. We're not authorized to sign off on any payment for hospice services. That's something that the director or the administrator at the agency would do. Now, because hospice doesn't always happen right away, or it happens down the line, and then hospice calls and says we need our consent signed. If our chairperson isn't available, we do, SDMC staff can sign off on the consent. We have things in place to enable us to do that. Next slide. Comfort care, medical care, and treatment provided for relieving pain and reducing suffering. And physicians cannot extend additional long or life-sustaining treatment restrictions that are not specified on the SDMC decision under a category of comfort care. So this is where if they're going to withhold or withdraw treatments, it would have to be most likely another hearing to add that on to the request. And panel members should clarify this on the record if there are any changes during the hearing also. Next slide. As Laura reviewed earlier, the most checklists should not be completed until they get the consent for the request. So once the consent is granted at the hearing, the most checklist can be filled out, and then the most from there. And we ask that everything is kept together on that. Next slide. And the most, if there's any changes on the request on the most, as SDMC as the consenting party for that, we should be notified as to if it's no longer needed, if any other requests are no longer needed, or they need to add further requests on. We should be notified in order to have the most updated information. And the next slide. And this is you, Cindy.
This is me. Okay, well, we're wrapping up right now. We love to have volunteers who are providers. You can always do things for other agencies if you work in this field, other things that you're not involved in outside of your own treatment circle. We have guidance documents on our website. All of the forms that we talked about, there are things that walk you right through the forms, even videos to show you. There's a mock hearing if you've never done testimony before. That's really cool for you to look at. And sample forms, you know, just an outline like I showed you what to put in these sorts of things. There are some samples in there. Next slide. Probably our contact information. There you go. You'll have
Contact us if you have any questions.
Absolutely.